Although now considered obsolete, angle-supported anterior chamber phakic intraocular lenses were widely used for the correction of high myopia in the 80s and 90s. This video will describe an unusual case of explantation of a Bykov model phakic lens implanted 25 years ago, followed by phacoemulsification and posterior chamber implantation, or more concisely, bilensectomy. The patient is a 50-year-old white female who presented complaining of decreased visual acuity in both eyes over the past year. CDVA was 20/40 in the right eye and 20/60 in the left with the refraction on the screen. Past medical history was significant for the use of SSRI class antidepressant and dyslipidemia. Slit lamp examination showed a well-centered phakic IOL, round pupils, and the presence of an 8-cut RK in the left eye. A 3+ posterior subcapsular cataract was present in both eyes. Panacam examination was significant for the usual central corneal flattening in the left eye. The Scheimpflug images of the AC lens were unremarkable. Preoperative specular microscopy of the corneal endothelium showed signs of chronic trauma such as low endothelial cell count for her age group, marked pleomorphism, and polymegathism. Macular OCT was negative for signs of edema or degeneration. She underwent phakic IOL explantation after pupil dilation and anterior chamber injection of high viscosity OVD. A fairly large scleral incision was made temporarily after conjunctival dissection and hemostasis. Manipulation of the haptics were performed carefully before a Kelman forceps was used to remove the lens itself. The leading haptic got entangled in the iris, which made more difficult to remove the lens. The anterior chamber was frequently redipped to protect the endothelium, and before the phacoemulsification itself, the soft shell technique was employed. The cataract removal and an aspheric 3-piece PCIOL implantation were uneventful. There was a fairly significant pupillary distortion even after injection of carbachol in the anterior chamber. On the first postoperative day, the slit lamp examination was significant for rare DSMS folds and pupil distortion with some degree of PAS and a cosmetically significant iridotomy at 10 o'clock. On the 10th postoperative day, she underwent an eventful YAG laser gonal synechialysis with improvement in pupil contour. The patient reported improvement in her vision but complained of its quality compared to the fellow eye, which had RK cuts. Post-operative CDVA was 20/30 with the refraction on the screen. The post-operative Z-wave aberrometry showed here, to our surprise, was exactly the same in both eyes. PSF and Wernicke RMS were consistent with significant aberrated corneas. The Bykov AC lens is a single-piece biconcave angle-fixated PMMA lens with a 5mm optic and a posterior angulation of 20 degrees, based on a multiflex Kelman lens. It was introduced in 1988 with Z-shaped large footplates to avoid iris wrapping, then later modified in its angulation of the edge to decrease endothelial cell loss, which was significant in the first studies. Complications of this lens also included pupillary block, halos, glare, iritis, implant rotation, iris retraction with pupillary ovalization. In the case at hand, the lens was a second-generation lens, as seen here. Phakic IOLs are the most predictable and stable of the refractive methods for preserving the crystalline lens in high myopia. The published results reflect an excellent accuracy and spectacle independence. The quality of the lens implant surface is above the optical limits of the eye. Its nodal point is near the pupil, and the optic can be conveniently wide, maintaining and potentially improving the natural properties of the eye's optical system to enhance the quality of retinal image, allowing excellent vision even in dim light conditions. This would be a plausible explanation for her overwhelming preference for the vision in the fellow eye. With the continuous improvement in design and surgical technique, since the first generation, there is only minor endothelial cell loss. Nevertheless, there is always some degree of endothelial damage during any surgery in which the eye is open. However, a permanent implant in the anterior chamber is a continuous risk for a progressive endothelial loss with cell abnormalities and marked pleomorphisms, as it is in our case. Dr. Alio showed in his reports of 7 years of follow-up the long-term relative risks these patients might face. According to the data, it might be 20-30 years before reaching the lower limit of endothelial cell count of approximately 1500 cells per square millimeter, at which point the eye may have decreased ability to sustain other types of surgery, including cataract extraction. This case illustrates, although with fairly good visual result, how explantation of these phakic lenses in highly demanding patients with low endothelial cell counts, light-colored irises, can be treacherous and challenging. Thank you very much for your kind attention.